with a nice tool. It's very simple. It's a table that's organized anatomically. Now, I don't think I covered this last week. If I did, I'm sorry for repeating. But it's a nice table in Lookingbill. And the bold orients you to the anatomy. And then in each anatomical region, there are common growths and common rashes. And I trust everybody can see this. And so you get face, you get trunk, you get genitalia, you get the groin, you get extremities, hands, feet. So if you're kind of not thinking clear because you're tired or fatigued, you can just look at the anatomical region, decide whether you're dealing with a growth or a rash, and come up with a differential. All right, so we ended last week talking about skin cancers, and obviously that's an indication to do biopsies. Just a few basics. I don't want to insult anybody, but a few basics that when you're anesthetiting the dermis, you got to go at a 10 to 15 degree angle, and you go in 3 to 4 millimeters, and you should be right in the middle of the dermis. If you go deeper than that, your anesthetic won't work. A good check is just do a little pulse on the end of the syringe, and you should see a little ballooning or bulging of the skin, just as a check, and the feel of it too. You should have some resistance. So no need to belabor that. When you do a punch biopsy, you're going full thickness. So you should feel that little pop. You want the full, if you have an indication for a full thickness biopsy, you got to get one, and that's to sample the dermis, in particular when you're looking for systemic disease, but also when you're dealing with a pigmented lesion, a melanoma that may be infiltrating deep. You've got to get the depth. So one little tip, just kind of know where your skin lines are, and you stretch perpendicular to the skin line. So when you take the punch, you take proportionately less in the axis of the skin line. So you wind up with a nice oval lesion. We don't put in many sutures after biopsy. If we do maybe 4 millimeter in a cosmetic area, we might do it, but not 3 millimeter. But even if you're not going to put in a stitch, you'll get a nice, a better, quicker result if you've got this kind of ellipse to deal with. But look, this is basal cell. This is the 85% I was talking about last week. And you don't need a full thickness. You just don't need a full thickness. Maybe it'll go down 1/3 the way. So a shave biopsy is perfectly fine. And the nice thing about a shave biopsy is you've maintained the integrity of the skin. When you punch a hole all the way down through the skin, you lose a little bit of integrity. And why is that important? I showed you last week that we could destroy basal cells, that they're shallow enough that we can go down and scrape and burn, scrape and burn, scrape and burn 3 times, right? You remember from last week. And it's easier to scrape and burn if you're not dealing with a full thickness hole. I mean, you can still do it. It's just you don't like to scrape as hard. You might snag the defect and cause more of a problem. Other ways of shaving, if you're dealing with a lesion that's recessed, so you can't get your scalpel handle into it, like the supraclavicular fossa or somewhere deep. This is a way to go down and sample and shave the tissue. So this is the old-fashioned Gillette double-edged razor, where we just bought it off the shelf and autoclaved it. Now there's a special device. I frankly like the Gillette better. This isn't quite as sharp, but I'm learning to use it. And they're available in the biopsy trays. All right, so that was a biopsy. I'll hang around at the end of the lecture. If you've got questions, I think that's the best way to handle it, rather than to try to coordinate stopping. All right, so we're working our way down the rank prevalence. We've done rash, and we've done infection, we've done that troublesome hair that keeps causing all kinds of problems everywhere and will continue. We talked about keratosis, we talked about cancer. So now let's talk about dermaphyte infection, fungus, and yeast. So this is a sample of a tricky problem. It's scaly, and this is Tinea capitis until proven otherwise. You just assume it, particularly in a young kid, who's a person of color. There are risk factors. And the last one was scaly. This isn't so scaly, but you got the black dots, And the reason you've got black dots is the tinea has shimmied down the hair follicle. This vestigial organ that doesn't do us any good, but just causes problems, and cut off the hair. And what's causing the black dot is the tip of the hair that's been eaten away by the Tinea capitis. And this is the hair itself with all the spores inside the hair. These are the different patterns. There are many patterns. We just talked about black dot. We just talked about and saw pictures of the diffuse scale. There's also gray patch. There's diffuse pustular. There's a carrion, a big boggy tumor looking like thing. But the bottom line here, as we do our quick tour, is a quote that I pulled out of the book. It's Tinea capitis until proven negative by mycological studies. What are those? Well, the books will say, oh, the first thing you've got to do is a KOH. Well, that's fine for derm clinic, but in the middle of family practice, and this is the setting we're talking about. We're not talking about dermatology in derm clinic. We're talking about dermatology in the lap of primary care. Here is a way you can very quickly get a culture. Now, the culture is going to take 2 to 3 weeks to come back, and we'll talk about presumptive treatment in just a second. But this is your dermaphyte transport median DTM, and this is Sauberod's. Either one is perfectly fine. So how do you get your specimen in there? You remember the open ring curette that we used to destroy basal cell? Well, now you use it to collect culture material. And you just scrape, it's got a dull edge and a sharp edge, but the sharp edge isn't very sharp. It's sharp enough to destroy a basal cell and scrape it out, but it's not sharp enough to cut the skin. And so you scrape into the scale and just plant it onto in rows. So you scrape and plant each scrape into 2 or 3 blots, and go back and do it and get about 25 little blots there. So you go and scrape maybe 8 times, and that's a good sample. And if there's fungus or yeast there, it'll grow in this media. Okay, the other place that you see tinea that's very troublesome in family practice is a Nicomycosis. Now, a Nicomycosis, the number one management pearl is to ignore it, and advise your patients to ignore it. Yeah, you can get into a big sweepstakes on getting rid of a Nicomycosis and take all these medicines for 3 months, but guess what? It's a exercise in futility. It comes right back. The only time you need to treat it is if it's painful. If it's painful, or if it's contributing to a paronychia, a staph infection. And there's a little bit of redness here, so you might worry about that in this particular patient. But if you think that it warrants treatment, then before you give them 12 weeks of Lamisil or terbinafine, you've got to get a sample. You don't want to give somebody 12 weeks if all it is a Nico deformity and not the actual fungus. So you clip that off and you put it in a bottle of formalin, just a bottle of formalin, the same formalin you put your punch biopsy in, and you send that off to the lab. Now, the tricky part in family practice clinic is collecting the damn thing. As you probably have personal experience, you clip a nail and it flies halfway across the room. So you get out one of those little blue drapes, and you put that over the patient's toes, and you tuck your hand and the instrument, peek under there, make sure you've got going to get a good piece, and then you clip. And when it flies off the end of the nail, you don't have to wind up on your hands and knees searching for it on the floor. Okay, so terbinafine, here it is at the bottom for a toenail. It's 12 weeks for a toenail, 6 weeks for a fingernail. So you got to be sure that what you're dealing with, and it's not that hard to do. You just get everybody's an expert at collecting their own nails, and you just have to submit one in a bottle of formalin. Now, for hair, those kids with the tinea capitis, that's going to be 4 weeks. But what we're about ready to see, which is tinea corporis, it can be gone in 1 to 2 weeks of terbinafine, PO. Now, there's a lot of terbinafine topical that you can use to treat smaller lesions, but let's look at that. You might try topical terbinafine here, but hey, what about the possibility that those are satellite lesions? And how do you know? And maybe it's mixed. So in the groin, what I'd recommend you use is not terbinafine, but a conazole, like ketoconazole or ecoconazole. And that covers both. So it took me a long time to tumble to this. Terbinafine just gets the fungus. There's some exceptions, but the rule is terbinafine just gets the fungus. The conazoles get both. But what about nystatin? It gets yeast, but it does not get fungus. And what about griseofulvin? It's like terbinafine. It'll get fungus, but not get yeast. So those are primary care pitfalls. All right, now.
Can I interrupt you? I have a question.
Sure.
What's the difference between yeast and fungus?
So the yeast is smaller. I'm going to show you some pictures in just a second when we get to tinea versicolor. So I'll show you the pictures. Can you hold on?
I can.
Okay, good. All right, so Tinea corporis. Man, oh man, this is ringworm, and what a ring this is. I've seen a few cases like this, and if you're just looking here, you're missing the forest for the trees. So usually there's some risk factor, like a truck driver. I've seen it on the back of truck drivers, people that commute a lot, particularly in the summertime when it's hot. Bedridden patients, you could have something like this on the back, particularly the sacrum. And obviously, this needs to be treated with terbinafine systemic, PO. And this will probably take 2 weeks. It's not going to take as long as the nail. Same thing here. It's too diffuse and too embedded to treat topically. So I'd go straight to terbinafine PO. This might be gone in a week. And then you hedge a little bit. There's some where you're not quite sure. This could be a mixed yeast and fungus. And so I'd go with itraconazole, and now you go PO with aconazole. So either itraconazole or fluconazole. It's pretty simple. KOH, if you want to see how it's done, fine, but you just don't have time to do it in clinic. And I've educated the dermatologist, Dr. Page, that's not going to happen. And so again, you culture. All right, now this is a fungus. If you were to do a KOH, you get these threads, chains, branching, and it's tricky because you've got to boil the solution, and that's another area you can either underboil it or overboil it. You just can't do it in family practice. So just to review, the reasonable systemic regimens, terbinafine, 250. Itraconazole is just 200 milligrams per day for 1 week, but pulse fluconazole just once a week for 2 to 4 weeks is enough. And griseofulvin if in certain cases.
I have a question.
Yeah.
On treatment, if like for bacteria, we're afraid of resistance, so we treat for like some randomly specified course that we sort of make up or we see online. But for fungus, is it kind of a similar idea, like the 7 days versus 14 days, or is it kind of like once your symptoms are gone and the skin's back to normal for like 2 days, then you like can stop?
Yeah. So what I tell the patients is take this for a week. And if it's gone, it starts getting better by day 3 and it's gone by a week, you can stop and hold that other week in reserve. And a lot of times they don't need it. But the manufacturer specifications say one to 2 weeks. It's interesting when you order it automatically on Epic, they give you a whole month. And it's one of the few things that I get that I mark down the amount that I give them less than Epic wants me to. I think every patient is different. We're not dealing with resistance. Now, you may get some surprises. You may think you're dealing with one kind of fungus and it comes back another kind of fungus, and they can they can group that by different kinds of fungus. So there's particular kinds of fungus, microsporum, that are we share with dogs and cats. So if you see microsporum, it's an interesting clue that, hey, wait a minute, we got to do some veterinarian consultation as well. So now, why is it important to differentiate between fungus and yeast? Well, we know that for yeast, the best example is Candida, and we're familiar with diaper rash, and we're familiar with satellite lesions, and we saw in the groin. But here is Malassezia furfur. You've seen it once before, and you're going to see it again. I'll explain. But it goes for areas where there's sebum, and Tinea versicolor is one manifestation. Tinea versicolor is tricky. This is looks dark, but it can infect certain parts of the skin and block the sun, and can appear light. So, but a lot of it is the pattern. It's not very thick. Malassezia furfur is normal flora. Everybody here has got Malassezia furfur. Only some people are susceptible to getting it. And where we saw it before was when we were talking about folliculitis last week. This is Malassezia furfur really taking off, chewing up that sebum, going deep down into the hair follicle. And for something like this, we'd give fluconazole 300 a week for 2 weeks. I'm going to give you a heads up. We're going to see Malassezia furfur one more time before the hour's out. Again, here is looking at the yeast, and here it's a little bit different than what we saw with the fungus. Yeah, you've got some branching stuff going on, but you've also got these spores. And Dr. Page likes to say spaghetti and meatballs. If you just get the spaghetti without the meatballs, it's more likely to be a fungus. But here it's a yeast, and it makes a difference because it helps us choose what we can use. So the other thing that I think is got to be a very reliable sign with good positive predictive value is evoked scaling. So, here we've got a blade, but when somebody's in a real hurry, you can just scrape it with your fingernail. It's something you've already got on your body, so you're not worried about there. There are some aesthetic objections I can understand. But you can scrape, and you can get a lot more scale than you would scraping normal skin. So this is a positive evoked scaling for Tinea versicolor. All right, so here's the treatment, high-tech treatment. Ketoconazole shampoo. This is 2%. You know, you can get 1% over the counter as Nizoral, and maybe 1% will work. For some reason, 2% is a prescription. Who knows why? Makes no sense at all. And it's just 5 minutes a day for 3 days. That's the first line. The second possibility is Selsun, but not Selsun blue, Selsun orange, which also is over the counter, the 2.5. Selsun blue is 1%. And this is messier and takes a little bit longer treatment. That's fungus and that's yeast, and I'll be around at the end to answer any other questions you have. But on we go to one more problem that hair causes, and that's acne which is really a sebum disorder, a hair oil. It's not the hair itself, it's the sebum that's causing all the damn problems. So here is Lookingbill. We look at pustular diseases. We've already covered folliculitis, the yeast, the bacterial. We've talked about impetigo associated. We've talked about candidiasis. Now we're talking about acne. And let's just review real quickly the sebum. This is oxidized sebum. That's what a blackhead is. And this is a mild form of acne. Some call it a papular acne or comedonal acne. But if the hair follicle doesn't open up and it remains closed, a closed comedone, then you get the back pressure and you can get a release of sebum into the dermis. And the dermis reacts to the sebum, probably the lipid triglyceride part, with inflammation. And so now you've gone from the closed comedone to the inflammatory lesions. And this, you can look at the pluses if you want, but you don't need to just go with mild, moderate, and severe. And that's really all you need to do. But I do want to go through the pathogenesis because it'll help guide your treatment. This is from Habif. I'm going to break it down. Here's normal. And this nice blue sebum coats, gives an oily coat to this hair. And, but under the influence of a surge of testosterone or androgen, what happens is the sebum proliferates, it even hardens, and you get something called cohesive hyperkeratosis, which is going to cause the blackhead. So this is your closed comedone, but if pressure builds up this pathway, the follicle pops open, and now the sebum is exposed to the air and oxidized and becomes black. If it stays closed, then we're going down this pathway. And so we're going down this pathway. It's blocked, back pressure, pop. Out comes the contents of the sebum. This is the kind of stuff that you get when you're doing a sebaceous cyst, where you get, if you pop the cyst, you get the grumous, combination of dead hair and old sebum. But now you have a stimulus for inflammation. So let's look at this anatomically. Anatomically, here's the cohesive hyperkeratosis, the hardening. Here, increased sebum production. Here, the rupture of the follicular wall. But wait a minute. Here is P. acnes, Preonbacter acne, and it's lurking, and it's going to be part of the pathology. So where can we intervene? Well, let's just go clockwise here. Here we can dissolve this comedone with tretinoin, topical retin-A. If you take oral tretinoin, that's Accutane. So this is the atom bomb, and I'll talk a little bit about that briefly. Here is the sebaceous glands going wild. You can block that with the estrogens, oral contraceptives in women. to turn off the androgen stimulus that's causing that. Let's not do everything. I'll talk about these other things in a minute. Moving over here, anti-inflammatory. You have somebody that's getting married and they've got a big zit that's going to be in all the wedding pictures. You can inject that because it's not an infection, it's an inflammation. So you can inject that with Kenalog, triamcinolone. Other things you can do for inflammation that are standard. Now, this P. acnes, this is where we use a lot of our topical medicines. The benzoyl peroxide is not is antibacterial. It's not an antibiotic, but it's antibacterial. And benzoyl peroxide also helps neutralize this hard hyperkeratosis. It kind of cuts through some of the lipid effect. Topical antibiotics, Cleocin is our go-to now. And then oral antibiotics. I sketched this out. That's looking at it from the microanatomical level. I'm just looking at it in more general terms. What happens in puberty, premenstrual state, you get increased androgen. You got to appreciate that hyperinsulinemia also increases androgen. So when you get increased androgen, okay, one of the things you're going to get is acne. But look at these other things. You'll see these things in your family practice clinic. Hirsutism, alopecia, pattern baldness, and acanthosis nigrans. I'll show you a picture of that. You've seen it, and you'll recognize it when I show it to you. So the androgen increases the sebum that causes that plug. You know about how it's going to cause inflammation. So that's my basic general map of what's going on. And here's how we intervene. Well, just how we intervene topically. This is where the retinoid and the benzoyl peroxide works against the sebum and the plug. Here's where the antibiotics prevent the inflammation from the development. But if the horse is already out of the barn, you can inject it with steroids. Don't be afraid. I'm only going to show you a little bit of this, and I'm even going to break that down. Okay, here we go. This is from the beef. If you want to go back and read the whole thing, you'll learn a lot about acne. HABIF. I mentioned it. It's the next level of complex dermatology for primary care, up from Lookingbill. So this is mild. This is the blackheads and the whiteheads. We start with retin A. And we give that 4 to 8 weeks. And, you know, if it's not doing as well as you'd like, add topical treatment, benzoyl peroxide or Cleocin, or both. Sometimes I'll go to the triple threat, which would be on all three of those things. You can also increase the strength of your retin A. We always start with the lowest, 0.025%, but it comes in 3 strengths, double that, 0.5, double that, 0.1. And if they're not responding and they're not having any side effects, which is kind of drying and irritation, then you go up to the next level. And it's hard to predict how high a level you need for a person to respond. So we always do step treatment, starting with the lowest strength and build up. So that's your other option. And And often if you're dealing with the poor papular, like that one patient that I showed you, if it's just pure papular, just keep grinding up your retin-A to max strength before you even resort to benzoyl peroxide or an antibiotic. All right, so something like this, I would go all the way up to 0.1, as long as they were tolerating it before I do anything else. Ditto, this one, papular acne. Okay, there's a little bit of inflammatory, but the predominant thing is papular. So what you're after is the predominant pattern, not that it has to be 100% papular, but it's 90% papular. This is 100% papular, or okay, 95. So this is a very common place to see it. The sebum here in the temple area is particularly abundant. Why? I don't know. All right, so now we've gone with the retinoids, and now we're going to start with this because there's a little bit of pustules on this one. It's hard to see from the diagram, but now there's a little bit of inflammation and pustules. So now you start with your retinoid, and you go to your topical antibiotic and benzoyl peroxide earlier, and you keep going. You give that a few months, and then you go to your oral antibiotic. And this is the level that you'll be dealing with most of the time in family practice clinic, not going beyond this. But let's go beyond it just for the sake of a discussion. Here, you got nodules. Now, I think this one, maybe you refer to dermatology, but here with this one, don't start the retin-A at the beginning. With this one, it's bad enough. You're sending the dermatologist, put them on the oral antibiotics and the benzoyl peroxide, but hold off on the retinoid until your antibiotics cool down the inflammation. The theory is that you add a retin-A to inflammatory lesions, you can cause it to at least aesthetically get worse. You may be getting to the basic problem okay, but you get a real flare that makes them so much worse that the patient's unhappy. So you get the inflammation under control with your antibacterial, your antibiotics, and then after eight weeks, add your retin-A. Now, Accutane Isotretinoin, here's a case where you need it, and it works, but this bad, again, these are high sebum areas, high sebum, oil glands here and here. And here's why you have to refer patients to give Accutane, because of the problems that they've had with pregnancy and malformations. This is the atomic bomb of acne. And so the pharmaceutical house has started this whole program to please the FDA that involves all these connections and lab and negative pregnancy tests for women every month at exactly the right number of days. And all this communication has to happen. And you can't do it. So don't do it. But one thing you can do is now we go up to the top here, and you can attack the androgen. If so far in primary care clinic, we've just been throwing on the topicals, but we can affect the androgen levels. I mentioned the birth control pills. And now comes spironolactone. How does that work? It doesn't work centrally, it works peripherally. And by affecting the local testosterone effect. This is Acanthosis nigrans. You've seen it, right? You've seen this kind of shaded. And when you see this, check for diabetes to make sure that they don't have high androgen from hyperinsulinemia. So that's the one thing that we order a lot in dermatology when we see this pattern. You've seen it. It's quite common. Often goes with obesity, which obviously also goes with diabetes. So the local effect of spironolactone, it can help hirsutism, by the way, right? You probably remember in my original sketch, Acanthosis nigrans is accompanied by hirsutism in women, and then of course in men and some women, pattern baldness. So you got too much hair and too little hair. That's how perverse hair is. But you can use spironolactone to treat all of those, by blocking the local effect of testosterone or the androgens. The birth control pills, particularly the one with this progestin, and that's Yasmin. Good old metformin can help with acne and hirsutism for that matter. And then you've got this category of medicines that peripherally blocks the conversion of testosterone to dihydrotestosterone, and that's the diethyl testosterone. When that conversion happens, then that's when you get a multiplication of by a factor of 10 of the acne stimulation. They're also looking on topical finasteride in addition to topical spironolactone. You'll see that in your clinical lifetime. It's just nobody pays for it at this point, but it's coming. So there's particular forms of acne that I want to talk about, particularly in people of color. For some reason, they get acne at the back of their neck, right at the hairline. Here it is, just starting out. This has been around a while. How do you treat it? Just like you treat acne, exactly like you treat acne. You follow the same algorithm, the step treatment. And it's called keloids. This is inactive, but it's healed with keloids, which is also a problem, a skin problem in people of color, more than in Caucasians. You'll remember this is a trick question. This is mechanical. This is not sebum. It's hair, but it's the hair that curls on itself. Pseudo follicular folliculitis Barbie. All right, so I think I've mentioned when we were doing atopic dermatitis that it's nice to check out what are the really highly effective local products. You go to Safeway and it's overwhelming. But if you go to your local Kaiser pharmacy and see what they're stocking, their dermatology department keeps up on this stuff and tells the Kaiser pharmacy, which anybody can walk into, by the way, what are the best and most effective, cost-effective products. And here they are, all the different forms of benzoyl peroxide. We start with 5%, but like here, but 10% you can go up to, but it particularly in combination with retin A, it might cause a kind of harsh chemical reaction and a dryness. The other thing I want to point out is the new over-the-counter preparation is adapalene. If you have somebody and they don't have insurance and nobody's covering retin A for them, this is a substitute for wherever you would use retin A in our step treatment. You could plug in differin gel. So that's fairly new. Okay, oral antibiotics. You only have to know 2 now. There are others, but I think primary care, you start off with doxycycline. The next step is minocycline, but you have to be careful with minocycline. There are more side effects, and I'll show you what they are for minocycline. It is more effective. This is a side effect of doxycycline. This is photosensitivity. And you need to know this, that if you have somebody that's going to a malaria country and they, for whatever reason, can't take the primary malarial prophylaxis, you'll see usually as an alternative doxycycline. Well, if they're going to a really sunny malarial country, they've got to know that they may get photosensitivity and they have to stop the doxycycline right away. Now, we have a lot of people on doxycycline for acne, and we always warn them. We don't see this that often, but it's certainly, you have to keep an eye on it. Minocycline, you can get this strange hyperpigmentation, but you also can get hepatitis. So you should probably monitor them if they're on minocycline for a long time. Not every month, but quarterly, every 6 months. And it can also cause a lupus-like reaction and neurological headaches and things like that. Special forms of acne, and I'm just checking on my time here. The jawline and the chin, just like the temple area, you can get late onset adult acne, particularly in women, the late 20s. For some reason, it'll flare. And I don't know if that relates to androgens or not, the menstrual cycle. Let's just quickly move on. I've got very little time. So not everything is acne. This is good old variety folliculitis that can coexist, and this is right near the nose, so that it could be a staph carrier. Is this acne? It is acne. Is it acne vulgaris? It is not. You don't see the comedones. So it's the absence of comedones. Now you're talking about acne rosacea, and we don't have time to go into acne rosacea, but it's usually people like me from Northern Europe, particularly people like me with Celtic blood that get rosacea. So Irishmen famously. Really bad case. Doxycycline is still the treatment of choice, but we're not sure why it works. And remember, I showed you when we were looking at folliculitis, that Demodex parasite that lives in some hair follicles, and 70% of the population. Well, it's been implicated as being part of the rosacea cascade, and possibly one reason why ivermectin is now a option for rosacea. Ocular rosacea can be debilitating. I'll end up with this terrible thing, hidradenitis suppurativa. This is the part of the eccrine gland, and no, let's see, wait a minute, I'm sorry, apocrine. And another disadvantage of having hair. Nobody knows exactly what the apocrine glands do, but they're located in distinctive places under the armpit, under the breasts, in the groin, and there's some genetic defect where you get these terrible focal acne that can be, if it's in the groin, absolutely debilitating. And what we're learning is some of the biologics can help with this. Okay, so we didn't quite get to psoriasis and seborrhea. I'm sorry for that. Then infestations, general rashes, and emergencies. But I'll hang around if people have questions.
Thank you, Dr. Lee.
My pleasure. All right, I'll stop recording, Stephen.
Okay. I will get an email as soon as it's ready, and then I'll get that over to you. Might be Did you start the recording?
I just did.
Okay.
And now I'm going to go to my